All right, real quick, let's hit the resus before and resus after, because I've mentioned this probably before, and you may have heard this before. If you try to intubate this person here, especially even if you just intubate them, you're probably going to make them sick. But if you give this patient sedatives and paralytics with their blood pressure of 76/37 and their heart rate of 46, they are probably going to die. They're going to get more hypotensive. They're probably going to develop some ischemia at that point, and the patient is going to arrest. We have to resuscitate this person. We have to try to resuscitate this person before and after the intubation attempt, because bad stuff happens. Specifically, hypoxia, worsening hypotension. But in about 2% of these chances, or in about 2% of critically ill patients that get intubated, the intubation results in a cardiac arrest. So 2 out of 100 times, which doesn't seem like a whole lot, but if you think of the number of critically ill patients that get intubated every day, about 2% of them we are going to send into cardiac arrest when we do so. This is a dangerous thing. So we need to resuscitate them first. We need to get them stabilized a little bit better before we go in and do this dangerous thing called RSI, or intubation for that matter. Now, one thing to keep in mind is the priorities. We think of, I got to do airway, got to get that airway. Oh man, his GCS is terrible. He needs an airway, he needs it right now. Keep in mind that most of the time, most people can survive with just basic airway maneuvers for a long time. Most people, you can stick an oral airway in, or a nasopharyngeal airway in, or just BVM, or put on BiPAP or CPAP, and temporize them for a long period of time. And how long is a long time? Well, let's say 10 minutes. Certainly plenty of time to start getting them resuscitated, and maybe even longer than that in most cases. Plenty of time to get this person a bit better, a little more stable than they are initially, because most of the time, the airway itself is not the critical thing. Fixing their hypoxia, their terrible hypoxia, yes, absolutely, fix that. But you can oftentimes do that without having to necessarily do the airway stuff, other than the basic airway maneuvers such as oral airways, BVM, good positioning, nasal cannula on the guy at flush rate while you're doing it. All that can happen while you're getting ready to intubate, or before you intubate. And then it's a lot safer when we avoid this 2% thing. So do this first. Again, the hypotensive patient, make them as not hypotensive as you can get them reasonably before you try to intubate them. I have toyed with the idea that probably, and a lot of folks may be just kind of borderline to start off with, and then as soon as we start delivering positive pressure breaths via an ET tube, they get really hypotensive. And why do people get hypotensive? Well, part of it is that we give them sedatives and paralytics, and we take away all their sympathetic drive, because now they're relaxed, and we take away all their muscle fighting drive that's driving their blood pressure and driving preload back to their heart. In addition to knocking out all that stuff, we are going to give them positive pressure into their chest. No longer are they sucking in with their chest. No longer are they doing that, which also sucks blood in from the rest of your body and improves your preload. We are delivering positive pressure, essentially making it harder for blood to get back into the thoracic cavity and decreasing your preload. All this results in you getting hypotensive. This is predictable. I can usually tell you somebody who's going to get hypotensive after we intubate them. And it is probably pretty reasonable in almost every case of field intubation, because these are sick people. In almost every case of field intubation, it is probably reasonable to go ahead and make up a little dose of the push-dose epinephrine stuff. You can either do that the way that I like to do it, which is take a 100 ml bag of normal saline, take either the concentrated epinephrine and inject 1 milliliter into it and shake it up, or take the whole carpuject of epinephrine, the dilute cardiac arrest epinephrine, inject the whole thing into the 100 ml bag and shake it up. Then I've got a 100 ml bag of saline and epinephrine at 10 mics per milliliter. And then I'm ready to go. I don't have to think about how to make this thing up later. I don't have to be struggling around trying to find it. Make this up before you make any sort of intubation attempt. Even if you're not using sedatives and paralytics, have a little dose, have your push dose epi ready, because if you need it afterwards, it's going to be that much harder to make it happen. By the way, other stuff to do, don't forget, you may need to start this guy and may need fluid resuscitation. Just getting a liter of fluid into the severely septic person who's really dry or it seems to be in shock otherwise may make a big difference. So don't forget about fluid resuscitation. Don't forget about hemorrhage control. If they're on, if you're going to start some peripheral pressors, start the peripheral pressors before you try to intubate them, because they're only going to get worse after you do. So resuscitate the patient first. Get the patient as stable as you can because they're going to be a little more unstable after you try to intubate them. The next thing about that is, along the same lines, don't let the patient start out hypoxic. If your SAT is above 95, you're probably at low risk for desaturation. If it's between about 90 and 95, you're at high risk for desaturation during intubation. And if you're less than 90, even if you are not technically hypoxemic, you are hypoxemic for all intents and purposes, because as soon as you stop breathing, you're going to fall off the edge of the cliff, as you can kind of see here. Now, if you haven't read the Weingart-Levitan article on pre-oxygenation, it's a really good review. It's easy to read. There's nothing that's like that has not been said before, but it's a really great put together. Here's the reasons and here's the ways that we can pre-oxygenate people to make them safer during their intubation. How might we pre-oxygenate folks? Well, in the spontaneously breathing patient, most of us will think of putting a non-rebreather mask on the patient. Okay, cool, that's fine. I would add a nasal cannula, as you see this guy at the top doing as well, and turn that up not to 6, not to 10, but essentially at flush rate. Now, it'll be fine. Don't worry about it. I know the thing's only designed to deliver oxygen at 6 liters per minute, but cranking it up is not going to cause the nasal cannula to explode. That said, it needs to be the nasal cannula with the prongs and not the capno cannula, because the one with the prongs is the one that will actually deliver the oxygen in the way that you want. So nasal cannula plus non-rebreather mask on the patient's face. And let them sit that way for about 5 minutes or so and let them get pre-oxygenated, meaning they've driven out all the other gases that we possibly can out of their lungs so that they have a big tank of air that your blood circulating past can continue to pull oxygen from. Pre-oxygenate them that way. If you can't get the person above 93, let's use 93 as our sign of like it's okay to intubate folks above 93, not okay under it. And I'll specify that again in a second. But if you can't get the person better oxygenated, then it is perfectly reasonable to actually use a BVM and supplement their respirations, especially if they have low respiratory drive, as most of these people will. You'll notice again that these folks have not only a well-fitting mask, but also the PEEP valve that you can't really see much of there, and again a nasal cannula underneath the mask that's set at flush rate. What they're essentially doing here is creating, if you squeeze the bag and you have it at a high flow rate, then you've essentially got a BiPAP system. If you don't squeeze the bag, it's essentially CPAP or PEEP, which is what you see next to them. Now, folks may say, and CPAP or BiPAP is a great thing to use for pre-oxygenation. Decreases atelectasis, delivers plenty of air, generally speaking, as long as you're using it right. Good thing to use for pre-oxygenation. Folks may say, well, what about if his mental status is bad and that's why I want to intubate him? Even if this guy's mental status is, 6, or a GCS of 6 or 7, something like that. If he's taking spontaneous breaths, I think it is okay to put some pressure on there if you think they will benefit from it because, they're terribly wet or they've got bad COPD or something like that. It is fine to put positive pressure mask on the patient in this case because it's not like we're going to put them there and hope that they get better and walk away. We're going to put the thing on there, let them pre-oxygenate as we're standing right next to them, watching them like a hawk, hoping that they get better and better and better. And if they start to vomit, okay, we'll pull the mask off them and we'll go with that. Now, if the patient's just not taking breaths, then yeah, that's not going to help them. There's no reason to do that. Go ahead and use the BVM. But it is a good thing to pre-oxygenate the person with CPAP or BiPAP if you can't get it done via normal respiratory mechanics of breathing with a non-rebreather mask. One thing to mention, too, if you happen to be in a hospital when this happens, somebody may say, well, I don't want to bring the CPAP machine in there and then have to fight the ventilator for it. What you can actually do is just take a CPAP mask, attach the ventilator to it, and set them on a pressure support setting, which basically is BiPAP for you. So that way you don't have to switch devices around. When you pop the mask off to intubate the patient, then the person assisting you just pulls the mask off the ventilator tubing, and you're all set. And by the way, the proof that things get better when you bag the patient and that you shouldn't start hypoxic, folks on the right side, this is a little bit, without getting too far into it, if you bag the patient in their pre-oxygenation, if you bag the patient up so that they are not hypoxic, they have a much less chance of becoming severely hypoxic or getting into trouble once you start to intubate them. So it is fine. People have this notion that you can't bag people before you intubate them or while you're doing doing while you're waiting for the paralysis to kick in. If they need the ventilation or if they need the oxygenation, then it's actually okay to do that. Like, that's just fine. Just be careful with it. Use good technique and gentle breaths of a not terribly high tidal volume. You will improve patient outcomes by doing so. All right, so don't start hypoxic when we intubate somebody. But if you can't not be hypoxic, it's still probably okay to push sedatives and paralytics. You say, what? Well, okay. Don't use an ET tube if the patient is hypoxic. If their SAT's less than 93, plan on using an iGel. And why do I put this in here? Just a little bit of trivia. iGel is the German word for hedgehog. So if you Google iGel first, thing that comes up is a picture of the cute little hedgehog. Isn't it adorable? You're right, anyway. Don't start hypoxic. If you can't get the patient pre-oxygenated with a SAT greater than 93, then plan not to reach for an ET tube and a laryngoscope. Plan to put a supraglottic airway in the patient. Don't think I'm going to make this intubation attempt, I'm just going to go fast. If their SAT is less than 93, put a supraglottic airway in and start bagging through that. Now, you may be able to get their SAT up after that. You may be able to use that as sort of a bridge to getting the patient to the point that they are no longer hypoxic. And at that point, if you decide that you want to try to put an ET tube in, all right, I guess you could do that. But if this is functioning, then I would probably just kind of leave it alone. If your SAT is greater than 93, it's probably okay to use an ET tube until your SAT is no longer 93 or higher. So if you're not hypoxic and you want to make this intubation attempt, make your first shot your best shot. We should do that by using airway checklists, by positioning, by sedation paralysis, and by using a bougie first. So this is the Air Care mobile care intubation checklist. You should go through a checklist similar to this with the 2 or 3 providers that are going to be doing the intubation immediately prior to it. And you should read it out loud, and there should be a call and response to each one, because otherwise you're going to forget something. We did the other day, I let this happen, unfortunately. We got a little bit off kilter, and this was in the emergency department itself, and we started to intubate a person and realized at that point that nobody had set up suction. Okay, bad on us. There was a lot of other stuff kind of going on with it, but bad on us. If you follow a checklist, if you make this mandatory and you document that you did it, then you are much less likely to create one of those errors of omission, even if you didn't mean to. So use a checklist. Patient positioning, big deal. You want to keep the patient never lying flat. Everybody should be up. They don't have to be up, to 90 degrees, but everybody should be at 20 to 30 degrees at least if you're going to do any kind of airway management. Not just if we're going to intubate them, but if we are going to bag the patient, if we're going to do CPAP, BiPAP, something like that. If we're sticking a nasopharyngeal airway in somebody, nobody should ride flat if we're having to do anything airway related to them. Keeping them upright will decrease atelectasis, it'll improve ventilation, it'll prevent any of the VQ mismatch that you get when you squish some lungs. And if you got a hefty patient, it will also keep the belly from, essentially squishing the chest when it falls backwards, because everything will be driven downward instead of back onto the patient's chest, and improve our ability to breathe and our ability to bag and pre-oxygenate these folks. So head a bed up every time and keep it there. You don't have to put them at 45 necessarily, but keep them at least 20 to 30 degrees of elevation while you're doing your airway maneuvers. If we are going to pre-oxygenate somebody, or if we're going to intubate somebody, they should be in this, props to Nicholas Crimes on this one, who made this graphic, flex tension, or the sniffing position. You notice this is not flexed, or not hyperextended, looking up the ceiling. It's not flexed down looking at their feet, and it's not just head to bed elevated. What they've done is you take the patient, and the way they describe it is that you lift their head up, and then you push their head down toward their feet, so that they're really just kind of sticking their chin out as much as anything. It's not tilt their head back. It's not just raise the head of the bed. It's forward and then keep the face parallel to the floor. Folks put this out for a while, and they say, well, look at this. You always said you need to do ear to sternal notch, right? Well, why should we worry about Come on there, Dot. There we go. Why should we worry about like ramping the patient up when what we can do is get ear to ear right here to sternal notch just by raising the head of the bed and dangling their head off the back. Look at this. I've done a great thing. Well, no, you actually haven't, because you've actually made it that much more complicated to intubate the patient. You've just changed the plane that you're looking at them in. This is bad. Don't do this. This is bad airway positioning. No, 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 no. This is a lousy way to do things. You're going to hurt people by doing it. This is not what that position is. Likewise, this thing at the top, this person where their head is just elevated, that is not the right position. What you've got here is the patient is, their shoulders are ramped up, and just ramping won't do it. Just elevating the head of the bed won't do it. Shoulders are ramped up, head is extended forward from the shoulders, and then their face is parallel to the floor. Same thing here, except instead of ramping their shoulders with a pillow, they've ramped it with the head of the bed. So you can raise the head of the bed up, but then you've still got to get the head forward of the shoulders. You got to stick that chin out. And then at the bottom, there's a couple of other pictures of the elderly person and the young person in the same way. So positioning is key, and it's not, don't just think of, I have to position them this way if I'm doing intubation. This should be for pre-oxygenation and any kind of airway management. Head forward, chin out, that flextended position. All right, how about drugs themselves? Should we be using drugs? Yes, we should be using drugs. Why? Because they increase the chance that you're going to get the thing on the first time. And why is it important to get the thing on the first time? Because every subsequent time increases the chance that bad stuff is going to happen. So this was one of the few studies that compares emergency RSI versus non-RSI, and your odds ratio was about 2 to 2.1, depending on what you were comparing it to, saying that RSI is better at getting the tube in the right place on the first or second attempt, with the same rate of major complications. So it doesn't seem to be any worse or more dangerous than non-RSI, and it seems that we get the tube in the place, or tube in the right spot, better if you use drugs. So it facilitates all the stuff that we want to happen. So therefore, I think we should probably be using drugs. We should put this out there. Now again, we have to be kind of careful about how we do it, and I'll show you exactly why in a second. What drugs should you be using? I would recommend ketamine and sux. Why? Because it's the same dose for each one, 1.5 milligrams per kilogram, and then it takes about 1.5 minutes for complete paralysis and sedation to happen. This is so that I don't have to remember anything else, and I don't really have to think about it. What do I want for intubation? Ketamine and sux. Pretty much every time. Now, I don't just not think about it at all. You do have to consider, okay, is there some reason I shouldn't? No, probably not, especially ketamine, and to a lesser extent, succinylcholine. These are pretty good because they work for almost everybody, with a few exceptions. Now, before you get into using it, yeah, absolutely, you got to learn the other drugs that you might use and why you might not use ketamine or might not use sux. But in my opinion, this is the way to go with it because we can offload ourselves from having to remember all the other drug dosages and all the other stuff about all the other drugs. And that is important. I'm a pretty good intubator. I'm a pretty good resuscitator, but I like not being able to have to do a whole lot of drug calculations. I've talked about using the bougie first. Bougie first? Yes, absolutely. What I mean is don't go in, if you're going to intubate, don't go in with an ET tube and a stylet anymore. Go in with a bougie first. Laryngoscope in the mouth. We find the epiglottis. We find the cords. We got a good view. Bougie in first, bougie's in the right spot. Now you can thread the tube over top of it. Why do that? Because it's easy to do. It increases the chance that you're going to be in the right spot. And if you end up with a difficult airway without good visualization, then you've already got your backup thing in the mouth and you're using it already. You're giving yourself the best shot at success to start off with. And we've talked about that previously. See my other thing on bougie first if you want to learn more about why I think you should do that. All right, and then finally, as we're intubating the patient, we can't let them become hypoxic. And let's say hypoxic is less than 93%. Now, this is that guy Jarvis that I mentioned before. This is a paper of basically comparing his services intubation stuff before and after a big intervention in the way that they did airways. So you take each of these blue lines, and each blue line is an intubation. the top of the line is where the patient's SpO2 started. The bottom of the line is where their SpO2 ended at the end of their intubation attempt, and this was with drugs. You'll notice that a good number of them fell not only below 85, not only below 90, not only below 85, not only below 80, but went down to as low as 20, 30. A decent proportion of these patients got severely hypoxemic, and a couple of them subsequently died. And so we have to be aware of that. If we let the patient get hypoxic, even if we get the tube on the first attempt, if the patient got super hypoxic like this, it doesn't matter. We've already caused them a whole lot of problems. You may as well have just not gotten the thing at all. Desaturation occurs as soon as you start taking fresh oxygen away from the patient. In a normal adult, you've probably got 10 minutes of good time where you can paralyze the person, just let them chill out, and they'll be fine. Their CO2 may climb a little bit, but for the most part, they'll be okay up till about 7 or 8 minutes, in which case they start to kind of fall off the cliff a little bit. Now, that is different if the patient is not 100% satting to start off with, because they're sick, like many of our patients are. You may only have 3, 4, 5 minutes. In kids, it's even less, and in the obese, it's even less than that. They may get hypoxic within 2 minutes. Before the paralysis actually completely kicks in, they may already be hypoxic. So it is not okay to just stop and say, well, I've almost got the tube, I just got to get it in right now. I'm doing the tube thing. Excuse me. It is not okay to let the patient get more hypoxic because we think we can get the tube. There are some things that we can do about it. One would be to provide apneic oxygenation. How do you do that? You stick a nasal cannula on the patient and turn it up to, again, not 6, not 12, not 15. You turn it until the dial on the regulator won't turn any farther, and it makes this huge loud noise. That actually will provide a little bit of pressure, and because your lungs are constantly filtering out and putting a little bit of oxygen out of the alveoli into the blood, oxygen is actually drawn into those alveoli, and you passively draw some oxygen down in there. It's kind of cool. Long story short, if you put a nasal cannula at that flush rate on the patient, you get about 2 more minutes of safe apnea time, which is a big deal. That should be enough to do all of our critical stuff, and there's fewer complications that happen when you see that. This just says the same thing. So we also can't let the patient get hypoxic. Say we put apneic oxygenation on them, everything's going okay, but just can't get the thing. We have to go back to this thing. If your SAT becomes less than 93, there is no, I've almost got it, wait a minute, hang on, wait, because by that point, SAT's already down to the lower 80s or in the 70s by the time that we actually realize what's going on. What we need to do is, as soon as we get to 93, when the patient has shown that they're not handling this super well, we need to stop and change course. If you're attempting to use an ET tube, stop when they get to 93. Pull out your iGel or pull out your King or whatever supraglottic airway or LMA you have. Stick that in there, which takes 10 seconds, something like that, because you had it ready, you're ready to go. Stick that in there, and then start bagging on the end of that. And again, if you can get them back up to 100%, you could try to re-intubate them once their SAT's greater than 93 again. But at that point, why? Realistically, this is working. Let's just go with this. As long as your SAT's above 93, you can continue to use the ET tube. But if the SAT ever drops below 93, just put a supraglottic airway in, and then you're set. Now, of course, we have to say that everybody should know how to do a basic surgical airway or percutaneous cricothyrotomy or use a quick trach, something like that. Yes, you have to be able to do that because that is the common pathway at the end. That's not that hard to teach. Now the question, did we do all this stuff right? How do we know we did it right? That -1A thing. It's not okay if the patient got severely hypoxic, but we got it on the first attempt. It's not okay if they got severely hypotensive, but we got the thing on the first attempt. Mostly preserving the hypoxia and the hypotension is the big thing, but it gets very hard to preserve those things if you take more than one attempt at it. So that's where -1A comes from. And you may say, well, wait a minute, that means that if I have to bail out and grab the iGel that I failed. Well, no, not necessarily. That's when they say definitive airway, where they specify it is insertion of any bougie advanced airway device, including tracheal tube or LMA past the lips or touching the scalpel to the neck. So if you put in a iGel, that's a definitive airway. successful advanced airway device placement, tracheal tube, cricothyrotomy tube, or supraglottic airway during the first attempt. So putting in an iGel, like, that's fine. And again, do I really care if, you bailed out halfway through and you stuck an iGel in rather than putting an ET tube in? No, not really. As long as the patient didn't get hypotensive or hypoxic and everything worked out okay at the end, the only thing the patient really cares about is those two things, hypoxia and hypotension. So if we can avoid that, successful airway. One last thing. Here is a successful airway in place. This could be a -1A attempt. One thing that you have to have, though, that you don't see on here is end-tidal CO2 stuck on the end of it. Every tube, every time, gets end-tidal CO2. Everything we put on the mouth, everything that we breathe something through needs an end-tidal CO2 sensor on the end of it. There is no other way. The tube is not in place until you have that waveform. To sum up, and we'll get out of here, when you're going to intubate somebody, and you should intubate some people in the right setting, you need to keep the head of bed elevated for any sort of airway maneuver. Ear to sternal nose position, that flex-extended position like that where you're sticking their chin out, is the way to go. Pre-oxygenate with a non-rebreather, non-invasive positive pressure ventilation, or BVM, whatever way you have to get oxygen into this person and get their sat up before trying to do this dangerous thing is safe. You just have to be cautious if you are doing anything other than the non-rebreather, but it is still safe with you standing there. You should do apneic oxygenation during all airway attempts, including those in cardiac arrest. Just stick the nasal cannula on and turn it up, and it's better than nothing. We should be able to sedate and paralyze people because that improves our chances. And how many people can you get an iGel? How many people can you force to deep throat an iGel before you realize that this isn't working very well without drugs? If your SpO2 is less than or greater than 93%, you can attempt to manage the airway with a bougie. If it's less than 93, you should put in a supraglottic airway. Why? Because the supraglottic airway is fast and goes in easy, and we're not screwing around anymore. The bougie first method, if you are using the ET tube, is the preferred method and will increase the chance that you are in the right spot on the first shot each time. Get to know the bougie, get to love the bougie, and start using it. But don't try to do it if you've never used the bougie first. Practice, practice, practice first. And then end-tidal CO2 goes on everybody afterwards. I bring this up just to close and real quickly say this was, again, Jeff Jarvis's paper where you saw all the hypoxia beforehand, how everybody started, maybe even severely hypoxic to start with. With the implementation of a bundle, essentially that I've described here, they got not hypoxic, they didn't start hypoxic, and they really didn't get hypoxic after because of those interventions that we put in. This stuff works. I'm not just making this up, and here was the time when it changed. So with that, I hope this gives you some tools. You should be able to RSI people, but we have to do it safely. You should be able to manage airways, but we have to do it safely. And it is going to take some practice, but if we give you the tools, we can hopefully work within the confines of what a service could actually provide to somebody, rather than the sort of pie in the sky thing that everybody is going to get 10 live tubes every year. So hopefully that gives you a little something. And otherwise, I appreciate you hanging around. Sorry about our technical difficulties, which stretched things out for way longer than I hoped that it would. Check out our website, emsgrandrounds.org, and our email is emsgrandrounds@gmail.com. My name is Walt Lubbers. Thank you very much from the University of Cincinnati, and we will see you next time.